Hello and welcome to the UVA Medical Center Hour. I'm Justin Mutter, Director of the Medical Center Hour, which is a program of UVA's Center for Health, Humanities, and Ethics. Thanks for taking an hour of your time to join in this important conversation on the COVID pandemic in global perspective. Today's event is offered in tandem with the annual Hayden-Farr Lecture in Virology and Epidemiology, and we're grateful for the collaboration of our colleagues in infectious diseases and global health in making today's conversation possible. Today's event is entirely over Zoom and in webinar format. And so when the time comes to enter the question and answer session of today's event, please send your questions through the Q&A option on Zoom. So the preamble to the 1946 Constitution of the World Health Organization is comprised of many famous statements, among which we find the following declaration, quote, "The health of all peoples is fundamental to the attainment of peace and security and is dependent upon the fullest cooperation of individuals and states," end quote. That we live in a highly interdependent world is increasingly a given, despite the social, political, geographic, and economic boundaries that we may try to sustain between various peoples and groups. The COVID-19 pandemic has arguably thrown this complex interdependence into relief to a degree not seen since the decades leading up to the founding of the WHO. Today, we're honored to be joined by Dr. Sylvie Briand, who will help us make sense of the pandemic and its seemingly endless impact on health, on healthcare, on social life, and global perspective of that interdependence. Dr. Briand is the director of the Global Infectious Hazard Preparedness Department at the WHO in Geneva, Switzerland. She has made extraordinary contributions to global public health through over 20 years of service, including but not limited to work on yellow fever, influenza, and more recently through COVID-19, including management of the, quote, infodemic due to the COVID-19 crisis in part that's working in partnerships with many agencies globally. Following the completion of Dr. Briand's presentation, our Q&A time will be moderated by Dr. Frederick Hayden, who is Professor Emeritus of Medicine and the Stuart S. Richardson Professor Emeritus of Clinical Virology here at the University of Virginia School of Medicine. Dr. Hayden has made a long list of contributions to medicine, science, and public health, which he has humbly asked me not to enumerate, but we are delighted to have him guide our conversation following Dr. Briand's presentation. And now we welcome Dr. Briand to the Zoom stage.
Thank you very much. Really, I'm really happy to be with you today. And thank you for inviting me to make this presentation. So I will share my screen. So again, so thanks a lot for inviting me. And I would like to first start with saying a little bit more about WHO, which is a specialized UN agency for health. And thanks for the quote, because I think it reflects really what is the role of WHO. But more importantly is to say that WHO is a member state-led agency. We have 194 member states, and they are our governing bodies, and they tell us what to do and how to do it. So our new Director General is Tedros Adhanom Ghebreyesus, and he's finishing his 5-year mandate, but we are in an election year. So in May 2022, there will be election for the Director General again. And so Dr. Tedros decided when he was appointed and elected to develop a global program of work, and it had with 3 pillars: serve the vulnerable, promote health, and keep the world safe. So Keep the World Safe is a program that is has been very prominent recently because of the COVID-19 pandemic. But I would like to mention that since the beginning of this century, we have seen a number of outbreaks and a number of epidemics and even pandemics. It started in 2003 with SARS, H5N1, H1N1, cholera in Haiti, MERS in Middle East, Ebola in West Africa, H7N9 in China, Zika in many countries in the world, yellow fever, Ebola, and now more recently COVID-19. So the world is really at risk for those epidemics and pandemics. And the role of WHO and its member states is really to develop global mechanism to make sure that epidemics don't become pandemic and that the world is safe. And so I will talk about it a little bit more, but the IHR, the International Health Regulation, has been updated in 2005 and came into force in 2007 and was for the H1N1 influenza pandemic in 2009. But every time we have an outbreak or an epidemic of a certain size, member states meet and decide on mechanisms that will help us to better manage the next one. So you see in this timeline below that we have had since the beginning of the century a number of agencies or mechanisms put in place to deal better with pandemic events. So one important point, of course, is after the Ebola outbreak in West Africa in 2014-15, there was an assembly where the member state decided to establish an emergency program at WHO, a program that is more dedicated to deal with emergency, whether there are emergencies from natural origin, disasters and so on, or infectious hazard emergency epidemics and pandemics. And so Dr. Tedros also, in keeping the world safe, decided also to focus a lot more on preparedness. And this is why my department is on preparedness for infectious hazards. So the IHR, the International Health Regulation, is well known, especially for the Emergency Committee, which is a committee that meets to decide on the intervention that will be needed at global level for epidemics and pandemics, and in particular, decision on travel measures that need to be taken to protect the world. This treaty is a binding treaty that came into force, as I said, in 2007. And in this treaty, member states must report, respond, and cooperate when there is an emerging disease, and WHO is in charge of the coordination. So let's go now to this COVID-19 pandemic. And now we are down the line more than 1.5 years after the start of this pandemic, which started in, as if you remember, in January 2020. But probably the first cases were before 2020 and probably in 2019. To date, we have more than 241 million confirmed cases and around 5 million deaths. And this epidemic or this disease has affected all regions in the world. And you see what is really important on this slide is first that the transmission is not a plateau and we have different waves, but the waves affect different regions at different times. And on the right side of this slide, you see that even if all countries have been affected, they have not been affected the same way. And the Americas, Europe, and Southeast Asia have had a lot of cases. And you see the scale is around 100,000 of cases, while the other region, Eastern Mediterranean, Western Pacific, and Africa, the number of cases for each wave is around 10,000 and 10,000 cases. So the scale is slightly different, partly due to the different population size, but not only. There are different dynamics in each region, and this is what we will look at in the next slide. So I would like to take the historical view on this pandemic and accompany you through the different stages of this pandemic. We have defined 5 stages, which are somehow arbitrary, but helps also to understand what were the challenge in each stage of this pandemic. And so it's interesting also from a global public health point of view, because understanding those pandemics help us also to better prepare for the next one. And we have faced at each phase different challenges, and this is why it's important for us to go through this historical timeline. So the first stage is, of course, the beginning of this pandemic, where we have a notification from China that they have a cluster of case of an unknown pneumonia. And this, we were informed of this cluster of case on 31st December 2019. And we asked the government of China to verify, of course, this event and tell us more about it, who was affected, what was the pathogen. And at that time, we didn't know really, it was a new coronavirus. What we knew is that some cases were linked to the seafood market in Wuhan, in Hubei province in China, that some patients died, especially older people and those with other medical conditions. And finally, 11th of January 2020, we happened to know that it was due to a coronavirus, and the sequence of the virus was posted immediately on the publicly available database so that the rest of the world could know what was the cause of this new disease. And at that time, in January at least, the disease was mostly in China. There were some exported cases in other countries in Asia, but there was no death outside Asia, and only 82 cases outside China. So you see on the map the location of those cases. And in end of January, the emergency committee met and decided that this was an outbreak of a public health emergency of international concern, which means that it was sending an alert message to the rest of the world, to other countries, get prepared for something that will certainly spread further. Unfortunately, at that time, many countries didn't hear this signal, this alert, and many countries didn't activate their preparedness plan. And so that's why a few weeks later, we had more cases outside China and outside the Asian region. What we did at WHO immediately is really convene the global research community and scientific community to already ask everyone to start looking for therapeutics, treatment, and a better understanding also of this disease. And so we had the first COVID-19 Research and Innovation Forum in Geneva, early February, 11 and 12 February 2020, where a global research agenda was developed, and all the researchers in the world accepted to work together to try to know as much as possible and as rapidly as possible about this new disease that was just emerged. So unfortunately, the disease spread, and we reached the stage 2 when it unfolds. And in March 2020, there were over 120,000 cases and 4,600 deaths, and in different countries in the world, in Europe, of course, in the Middle East as well, and some sporadic cases in other countries in the world. What was really interesting at that time is to see that we had already different countries, different situation in different countries. Some countries had no reported case, so they were completely free from COVID-19. Other countries had sporadic cases, mostly imported cases. Some countries had cluster of cases. And finally, some countries had already community transmission, wide community transmission, and were really struggling with difficult outbreak to contain. And so many countries who were struggling with those outbreaks decided that we cannot stop the transmission. At the beginning, some people really thought that maybe we could stop this virus, we could stop the transmission, as it was done for SARS in 2003. But it's a different coronavirus, and we realized rapidly that it was spreading faster and creating more outbreaks than the predecessor in 2003. So many countries, because they were facing large outbreaks, they decided to only flatten the curve. to protect the healthcare system, because some healthcare systems are completely overwhelmed with the number of cases and they really couldn't attend so many patients at once. And also it was very hard to really know where the disease was in the absence of good contact tracing. And so that's why many countries decided to take very stringent public health and social measures, and closing schools, shops, workplaces, bars, restaurants, as well as border, to try to contain this disease and to gain time in order to have more capacity to deal with it. Health systems were under huge pressure, even in very wealthy countries. They lack personal protective equipment. In many countries, there was no mask, oxygen, ventilators, and also COVID-19 tests. And at the beginning of this pandemic, many health workers were infected because they couldn't get the right protection, and they had also too many cases to deal with. And so in October 2020, 14% of the global number of cases were in the healthcare worker population. And what happened as well is that usual healthcare was cancelled in many places. And so people who usually needed treatment for cancer or other chronic disease couldn't have access to their treatment, which also in turn increased the mortality, the overall mortality. Even if it was not directly due to COVID-19, still it had an impact on global mortality. So many countries put in place what we call public health and social measures, and we look at it as the Swiss cheese respiratory virus pandemic defense, where no measure is enough used alone. And you need to put a number of measures in place to make sure you have a real control on the disease and its transmission. So those measures are individual measures, of course, hand hygiene, respiratory etiquette, face mask, travel-related measures to stop the spread of the disease internationally, border closure, travel advice, travel restriction. Also, you can have these physical distancing measures, which is contact tracing, isolating cases, isolating contact, reducing school attendance, workplace measures, and avoid crowding as well. So all those measures try to put more space between people so that the virus has more difficulty to transmit from person to person. And finally, environmental measure, cleaning surfaces to make sure that people cannot be contaminated by fomites. So the stage 3 is really the acceleration of transmission. Really, now it's clear that we are not going to be able to stop the transmission. We need to just slow it down and make sure that countries are prepared to see this virus coming so that they put in place the right measure at the right time. At that time, we are in July 2020. We have more than 10 million cases, over 500,000 deaths, and 215 countries and territories are infected. And we have also a number of outbreaks reported in cruise ships, for instance. And so this requires a very specific measure as well. What we know about the disease is that still it's people, elderly and people with underlying conditions are more at risk for severe disease, but we see a lot of cases in young adults, but usually they have mild symptoms or even asymptomatic, and they contribute to the transmission, of course. And so this is the epidemiologic patterns we have seen since the beginning, and it's confirmed as the disease moves from one country to another, with some differences, of course, depending on the demography in each country. And so you see here that age and comorbidity are really risk factor for severe disease and mortality. And so this is why specific measures are put in place for those people who are more vulnerable and are more at risk to get a severe disease and die. What we have seen, although it's very surprising, because initially we thought that developing countries would be much more affected, but at the stage 3 of the pandemic, we see low cases in Africa, for instance, and the mortality is low as well. And so we don't know if it's because of reporting, that they have less capacity to test, for instance, and to report cases and deaths, or it's because they have also a younger population, they have pre-existing cross-immunity, or if they use local treatments like ivermectin, for instance, that may have had an impact, at least on the mild cases at the early stage, and we still don't know about it. So, but what characterizes this stage 3 epidemic is really the fact that all those public health and social measures, although very useful to reduce transmission, to slow down the spread of the disease, had a huge impact on societies. Lots of national restrictions led to a huge impact on businesses, and individuals lose jobs. The travel sector was greatly affected by international movement restriction, and there was a lot of pressure to reopen societies, including schools, in order to minimize the social and economic disruption and impact on societies. And in summer, at least for the Northern Hemisphere, summer 2020, countries start to reopen societies, and we have seen consequently an increase in transmission after the holidays, and especially when school started again. Sorry. So the stage 4, really, we ended up with a really multifaceted pandemic, because certain countries were finishing their first or second wave. Other countries were just starting to see cases and to deal with this amount of cases. For instance, in this phase, we have sustained transmission in the US and India, a new increase of cases in Europe, but some other countries remain relatively spared, like New Zealand, with just cluster of cases that are easily put under control. And so this multifaceted pandemic makes things very complicated at global level, because you have a different status of the epidemic in different countries, and so the measures implemented are different. And for people, it's often very complicated to understand why, for instance, there is no school in certain countries, but in other countries it's still open, while you cannot go to certain places, but in other places it's completely open. People don't wear masks, people do whatever they want. And all those kind of things are really hard to communicate and to make people understand that we try to adapt the measure to the epidemiological situation, to local context, so that we can not only tackle better the disease, but also minimize the impact on societies at the same time. In this phase 4, it's November 2020, and there are 46 million cases and over 1 million deaths. So at that time, during that time also, we try to see what can we do at global level, and of course, all the countries, but also partners, very important partners in global health, like the Bill Gates and Foundation, also other UN agencies, UNICEF, the Gavi, the CEPI. We all came together and we tried to have an effective partnership to have an end-to-end process from research to implementation, to accelerate the development, the production, and the access to COVID-19 vaccine, therapeutics, and diagnostics. But at the beginning, we had a lot of products in development, but not many products already accepted or ready to be used. But it has been very fast. But in November, still, we didn't have any vaccine close to being used, but we had dexamethasone confirmed as a useful therapeutic for treatment, and also a new antigen-based rapid diagnostic test. At the same time that we were accelerating the development of those countermeasures, we also developed a global framework for an equitable access to make sure that if we have a life-saving intervention, we can also make sure that everybody will have access to them. So one particular challenge we faced is really this myth and disinformation. We call it, the overall phenomenon an infodemic. It's a tsunami of information, some accurate or some not, that spread alongside an epidemic and a pandemic. And this infodemic has to be managed, because otherwise what we have seen is that misinformation has generated mistrust. in many countries, mistrust in governments, in public health authorities and public health measures, and in science as well. And when you have mistrust, it's very hard to control an outbreak, because the best way to control the outbreaks is to create a trust system where everybody understands what has to be done and everybody adhere to the measures. If there are dissent and if nobody is in agreement on how to control the disease, then the virus take this opportunity to spread even faster and reach to a vulnerable population. And what makes it very complicated to manage infodemic nowadays, it's because we have the social media. So on one hand, it's really nice because we can communicate faster and the entire world is connected. But on the other hand, rumors, misinformation and disinformation spread also faster. And this makes our job extremely complicated. So the stage 5 is where we are now, and we have countermeasures that are available. Even if we still have a lot of cases, now the vaccines have been rolled out, and we see really a decrease in number of deaths in many countries. When we started this phase, it was January 2021. We had 83 million cases and 1.8 million deaths that were reported at that time. So where are we now? We have 6 vaccines that have received approval by WHO, but other countries have approved more vaccines. We have very different platforms for those vaccines. We have 124 vaccines in clinical development still, so more product to come. And currently with the available vaccines, 6.3 billion doses have been administered globally. Regarding the treatments, 7 treatments have been evaluated by WHO. 3 treatments are currently recommended. It's corticosteroids, IL-6 receptor blockers, and neutralizing monoclonal antibodies. And 7 other therapeutics are still under assessment. So regarding vaccination, we see a high vaccination rate in many countries, but in other countries, really the vaccination rate is extremely low, especially in developing countries. And you see in those maps that the red countries is where we have less than 3% of the people being vaccinated, and sometimes it's less than 2% even, while in other countries you have sometimes the vast majority of the population being vaccinated and even ready to receive the 3rd dose. And so this disparity, it's concerning because we see still high mortality in developing countries, but also because having this kind of disparity makes easy for variants to emerge. And this is what we have seen, and I will talk about it later. But here I just want to highlight also that we see a huge impact on society, and extreme poverty has increased a lot and is going to increase even more in the coming months. And so we need to also to be ready to face this new wave of problems and challenges for our society. So as I said, what has emerged is variant, meaning that the virus is changing. And this is normal for viruses. Viruses are always changing. But for us, it's a challenge because we need to see if the product or the countermeasures we have are still effective for this new variant. And currently, we have 4 variants of concern: Alpha, Beta, Gamma, and Delta. We have also some variant of interest that we are monitoring to see if they become of concern, but so far, so good. But for those 4 variants, what we have seen is that definitively there is an increase in transmissibility. For the disease severity, it's not very clear. And at least Alpha, Beta, and Gamma, we think that there is no increase in severity. Maybe for Delta, we see an increased risk in hospitalization. But it has no impact on diagnostics so far. And regarding vaccine, it's very hard to analyze the vaccine effectiveness in the current environment. But it seems that the vaccines are still very effective against those variants. Even if we see a slight reduction in effectiveness and efficacy, it's still acceptable, and it's still an excellent tool to reduce severe disease and mortality. And this is what aim currently of vaccination strategy is to protect vulnerable people from severe disease, hospitalization, and death, because we know that the vaccines are not so good to protect against the transmission, although they may have an impact also on transmission. But really, the strategy now is to use the vaccine as a real tool to save lives, and see how we can by that really reduce the burden on the health system and protect a health system for the next waves. So you have heard that currently there is a lot of discussion of booster doses. And so why should we give more vaccine to people? First, we do this when we see waning immunity, and it has been reported, but we are not sure yet if when we see less antibody, it means that people are less protected, because we know that there are other immune responses that are not necessarily tested with the measurement of neutralizing antibody. So there are still a lot of unknown regarding the real protection of people. But what we know at least is that natural immunity seems long-lasting, especially in young and otherwise healthy population. And some publications have happened to this. But we have seen also waning immunity, especially in people with immunosuppression or other underlying conditions. And so for those people, of course, it's interesting to consider an additional dose of vaccine so that they can be even better protected. So what are the factors driving transmission currently? First, the virus continues to evolve and becoming more transmissible. We also still have a lot of people who are really susceptible because they have not been vaccinated or because they have not met the virus yet. So that's why we need to still be very cautious and continue to apply the personal protective measure and wash hands and the ventilation of closed space and physical distancing, because the virus is still with us and can continue to infect people and even produce cases and deaths if we are not careful. There is also increased social mobility and social mixing, and so this provides also opportunity for the virus to spread. And finally, we have still misinformation, disinformation, conflicting messages, and politicization of the crisis that doesn't help for the implementation of measures. Last point is really what will happen this winter when we will have maybe other respiratory viruses circulating as well, like influenza and RSV. So what we have seen since the beginning of the pandemic, very surprisingly, is that very low level of influenza transmission. Last season was extremely quiet, very low level, so which is nice, but it's also a bit worrying because it means that during 1 year, people have not developed antibodies against flu, and so we really don't know what will happen this season. So if you have the possibility to get vaccinated against flu, please do so, because it will protect you from severe flu. The other thing with RSV activity, we have seen that we still epidemics of respiratory syncytial virus, but they have occurred out of season. And so it requires also a careful monitoring to make sure that people, if they don't get COVID, they get other respiratory viruses. So we need really an integrated surveillance, multi-pathogens, to make sure that we have in our radar all those different viruses. And with this, I end my presentation. I've put at the end of the presentation, and you will have the copy, all the resources you can access and that have been used to prepare this slide set. And with this, I really thank you for your attention. Many thanks. Sorry, I clicked on the wrong.
Sylvie, thanks so much
links.
for really outstanding presentation. And you've really done a very thoughtful and comprehensive job of bringing us up to date on the status of the pandemic. But that, of course, raises the question of where we will be heading going forward. In this regard, I just wanted to get back to one of the concepts that's been discussed a lot, and that's herd immunity. And as you pointed out, some of the variants, especially Delta, have a much higher transmission risk than the original virus, and this does impact, of course, on the levels of herd immunity that will be required. Perhaps you could comment on that for us.
Yes, so indeed, at the beginning of the pandemic, because it was zoonotic viruses, we thought usually zoonotic virus, they spill over to human, but they are not fit for human body, so they don't transmit so easily. And this is what we have seen with MERS, for instance. With MERS, we had few epidemics, but it never became a pandemic. The transmission was self-contained. These viruses don't spread very easily. And we thought maybe it will be the same type of virus, but we have seen that no, this virus initially was already more transmissible. We have seen very early on human-to-human transmission and sustained human-to-human transmission. So now we see that this virus will continue to circulate. And what is really challenging is that first, a lot of people are asymptomatic, so they don't know that they carry the virus, so they can transmit the virus. So for us, it's hard to know where is the virus exactly. And especially at the beginning, we didn't have enough testing, so we really knew only that some people were infected with COVID-19 when they were going to hospital, basically. So this was the challenge at the beginning. Now we have better testing, so we are able to know where is the virus. So we think that quite a proportion of the population has already been infected, have met the virus once, but it's still very difficult to know if people have developed immunity or not, because the test we use, what we use to measure the immunity is really the antibodies. And people with mild disease, they tend to develop a low level of antibodies. It doesn't mean they're not protected, but we cannot find the sign of this protection necessarily with the tests we are using currently. And so we have a significant issue with measuring really this herd immunity. So with what we try to do now is really, as the priority strategy, is to reduce severe disease, hospitalization, and mortality. Because this is what makes this disease so scary, is when you see your family relatives dying of COVID-19. And so this is what we try really to focus on currently. Knowing that at some point in time we will have more people vaccinated or more people with a natural immunity, and so we will have certainly a high level of people that have enough defense to cope with at least mild disease. So there will be herd immunity, but when we don't know yet, and how strong will it be? We don't know yet. And also, we don't know how long it will last as well, because we have seen that probably this immunity may wane over time. And so we might need to look at also having another round of vaccination at some point in time, but we don't know yet even when this will have to happen.
So from what you're saying, this virus is going to be with us for a sustained period of time, if not indefinitely, going forward. I appreciate that we don't have an agreed surrogate for protection, either in terms of infection or even more severe disease at the present time in terms of immunologic measures. But I think if I understand correctly, there are some very interesting data emerging from the surges that are occurring now in Europe, and particularly the UK, where their case numbers are going up, but there's not a parallel increase in terms of hospitalizations and death, at least to date. And this, I assume, is in part attributed to the relatively high vaccine uptake in those affected countries. Is that correct?
Yes, absolutely. We see that this vaccine is is really good to prevent severe disease, hospitalization, and death. And because we have seen, even if in those countries we still have a number of cases, really the curve, the mortality curve is on the decline, and very significant decline. So it's very encouraging, because it means that this vaccine is helpful. Even if it doesn't stop the virus spread, at least it protects the most vulnerable from dying from it.
Just a couple more points on vaccines. I did look at our local figures here in the Charlottesville area, and I was a little bit disappointed to see that according to the website that I consulted, overall for the 12 years and older population, we're only at 54%, and for the 65 and older, only at 70% currently. And clearly there's a long way to go to enhance those kinds of numbers. But one active area of discussion, as you know, in the United States right now is launching pediatric immunization. It appears likely that there will be approval of at least one of the mRNA vaccines, and shortly thereafter, perhaps the second one for pediatric use from those 5 or 6 years and older. I was wondering what your views on that were. Should you, for example, recommend restriction to those who have underlying risk conditions?
Well, what we see is that because this vaccine, most of the vaccines, there are different platforms as you highlighted. So, but most of the vaccines are really useful to prevent severe disease. We think that it's very important to protect people who are at risk of severe disease. So, of course, not all the young people are at risk. And we have seen low mortality in young people so far, but at least it's very important to vaccinate people with a high risk condition or high risk exposure, or at risk to have a severe disease. What we have noticed since the beginning of the pandemic is, of course, there is a particular vulnerability of certain people because they have a weak immune system or some underlying condition like cancer, cardiovascular disease, or obesity, or other conditions that make them more vulnerable. But we have seen also that there are dangerous situations. For instance, when you are in a very a poorly ventilated space where people are doing a lot of exercise or singing or expelling a lot of virus, you are more at risk to have a high viral load at the infection, and so more at risk also to develop more severe disease. So I think the deciding on vaccination needs to take into account those two situations. One is the vulnerability of individuals because they have some underlying condition, and then the type of situation they are in and the exposure they are in, because even if they don't have underlying conditions, they may be at risk still to have severe disease. And so, of course, it depends on the country. It depends on the social mixing patterns. But so that's why every country has to develop its own policy in this regard. But I think it's important to protect all the people at risk from severe disease and death.
So let me just change the topic a bit. Of course, one of the concerns that we've seen is the proportion of patients who've had long-term symptoms and associated disability. People have talked about this epidemic of long COVID within the greater pandemic context. Perhaps you could say a few words about WHO's response with this problem.
Yeah, so first, for us, it has been, the approach has been to collect data from different countries to understand what was this phenomenon, and also to agree on a common definition across the world, because certain symptoms were counted as long COVID in certain countries, but not in other countries. And so we needed to have a kind of a common understanding of what is it and also how to describe it. So now this is done. And so all countries agree more or less on what could be the definition of long COVID. And it's very important to have this because also for physicians, then they know what kind of symptoms they need to look for and what kind of care they need to provide to those people. And the group of clinicians that, and Fred, you know this very well because it started with flu and groups that you convene and you set up. The group of clinicians around the world are also looking now at what kind of advice and what kind of treatment we can provide for those patients. It has implication, of course, for in the world of work because it may lead to a longer-term disability. So this is also these are also discussions we have with the ILO as well and other agencies that are in charge of looking at the impacts on the world of work and indemnification and so on.
No, just out of interest, when you're collecting these data on long COVID, do you see important differences in different regions or different populations around the world?
Yes, we see it because, for instance, in certain countries, people have there is high rate of anemia, for instance, in a woman in a childbearing age, for instance, and so they are very tired, but it doesn't mean that it's necessarily linked to COVID-19. So it's more to also assess certain symptoms in the context and making sure that they can be attributed to COVID as well and not to other pathology that are also endemic in those kind of settings. And then as you know, health systems are very different in the world. So some weak health systems as well, they have difficulties to ascertain I mean, the status of the people. So we also try to develop guidance that if you don't have tests, if you don't have capacity to diagnose it, how can you still better provide care to those people who are affected of long COVID?
So one of my colleagues, Kosti Sifri, our hospital epidemiologist here, asked what you and WHO have learned regarding control of this event pandemic that you didn't know prior to COVID-19, and what lessons will have been learned in terms of perhaps making changes to the international health regulations going forward?
Yeah, I think we have learned many lessons, and you know, I've been through many epidemics and pandemics since the beginning of my career, and I think I become more humble each time I face this kind of event, because even if you think that you have learned a lot in previous crises, the new one still is teaching us something. So what we have learned, for instance, is, as you rightly said, is the limit of the IHR. Although we used the IHR in 2009 for the H1N1 pandemic, it was the first time at that time, so the IHR was not really appropriate. I mean, the way we implemented it, there was a lot of difficulties, and we thought that we had overcome those difficulties, and this time we will use it much better. But still, we have seen that, for instance, the IHR is not really suited for a purpose for sharing information that is not epidemiological information. For example, sharing genetic sequence data is not mandatory in the IHR. So this is something maybe we can improve, adapt the IHR to the new technologies that allow us to have more data, more information, and make sure that this new type of information can be shared very quickly also under the umbrella of the IHR. And the second thing we learn also is that the IHR is really good at the very early stage of the pandemic, when WHO has to coordinate the alert phase to tell all the countries this is what is happening, but it's not sufficient for ensuring the collaboration over the months of the pandemic, because it's a long event, and you need coordination at different stages, and the IHR doesn't provide necessarily the right ecosystem to do so. So probably we need to look at this more with more attention. Also, what we learn is that in time of pandemic, it's very difficult to ensure equitable access to countermeasures, medical countermeasures, because each country is trying to protect its own population first, which is legitimate. But the problem is that when we deal with the pandemic, we are on the same boat. So we should have approaches that are really collective and international by nature. And so it's very difficult to have this equitable allocation, and we need to look at options for the next pandemic, because it will happen again. And if we don't have a strong system in place before the crisis, it's very hard to develop them when you are in the crisis. And finally, I think very positive thing from this pandemic that we learned is that the research is absolutely instrumental. We have done a lot of progress in the last pandemic, influenza pandemic, even more after Ebola, with the R&D blueprint, with the CEPI and other agencies. So I think we need to continue to push for very active and dynamic research during crisis. And we need to develop protocols that are even more agile, so that we can collect information more rapidly for the next pandemic. So there are many other lessons learned, for instance, that we need to really get better prepared and work partnerships before crisis. Also work much more with communities, because they are the front line, so they need to understand what is an epidemic, what they can do at individual level, but also at community level. And you were mentioning this issue of low vaccine coverage, and I know that a lot of people are really afraid to get vaccinated, and I think this is where we can also improve next time, is having trusted sources of information on health issues, and make sure that people can access those sources of information and be able to reassure people, tell them exactly what we know, what we don't know, so that they can make healthy choices for themselves and their family and community.
I certainly support what you said about the clinical research response. I think we've learned a tremendous amount with platform trials like Solidarity that WHO ran, but also Recovery in the UK, and ACT and Active here in the United States. And I think hopefully some of the lessons we've learned about treating COVID will be taken forward in terms of treating severe influenza and other respiratory viral infections. So I did want to return in the last minute or two of the Q&A to your special area of interest, and that's the infodemic. And in part because it goes beyond even disinformation. We now have political figures involved in giving out incorrect medical information. How can WHO or others respond more effectively under those circumstances?
Yeah, so first of all, I mean, we have, this infodemic situation, the tsunami of information that accompanies an epidemic. We have seen it also with Ebola. For instance, there was rumors that if you go to an Ebola treatment centers, the white doctors will take your organs and send them to other countries. So we have seen this kind of rumors in every epidemic. But I think what is really difference with COVID-19 is just first the global scale of the epidemic, which is a pandemic, and the global scale of this infodemic amplified by social media. And so even if one politician says something in one country, we know that it will be distributed and amplified around the world in a matter of hours. So what we have done to try to mitigate the impact of those the misinformation, at least. So first, we have differentiated disinformation and misinformation. Misinformation is really inaccurate information, but there was no intent to harm anybody. It's just inaccurate. And disinformation is really inaccurate information, but that is spread with the intent to harm people. So it can be for business reasons because people want to sell fake medicine, or it can be for political reason or many other reasons. But and so disinformation is slightly different for me, and WHO is not really in a position to influence disinformation, which is more requires more legal action rather than what we can do at our level. But misinformation, we are really working on it. First of all, by monitoring population's concerns online. So we have developed new tools based on artificial intelligence to listen to population's concern and try to understand today what are the questions people ask on masks, on vaccines, on the epidemic, on whatever, so that we can also shape messages that answer the direct concern of the day, and not blanket messages that are sometimes not well received or not well accepted by population. So for us, it's the right message at the right time and the right format to the right audience, and this is what we try to do. The second thing that we try to do also is to find amplifiers. So for example, universities are amplifiers. I mean, if people with are interested in knowing more of the disease can also correct misinformation and spread good messages, it's very important. So we have developed materials also for people who can amplify the good information. We have also developed a global network, for instance, with faith-based organizations, with World of Work, with the youth organization, so that we discuss with them and we co-develop the message or the guidance with them, so that they understand what is at stake, and then they can relay the messages or the advice to a different audience that are not necessarily looking at WHO websites, which I understand because it's a bit messy website sometimes. So it's better if it's done through other relay, and this is how we try to make sure that people have access to the right information.
Sylvie, thanks so much for taking your time to be with us today.
It was a real pleasure. So thanks a lot. Very happy, and I'm welcoming any other question, if any, by email.
I'll turn it over to Justin.
Thank you, and let me thank you as well, Dr. Briand. Thank you, Dr. Hayden, for joining us for this really important conversation. I want to thank all of our attendees today, and also remind you that for eligible participants, you can claim continuing education credit for today's event. And please follow the directions at the bottom of the handout that will be posted as slides here at the very end to claim that credit. Please join us next week as we welcome Dr. Laura Colby, a poet, assistant professor of medicine, and an ethicist at New York Presbyterian Weill Cornell Medical Center. Dr. Colby will be presenting a talk entitled Off the Chart, Elegy, Ecstasy, Dissent, and Other Subversive Modes of Clinician Creative Writing. That event will be held in person as well as on Zoom. And so for those of you who are able, we invite you to join us in person at the Penn Hall Auditorium at UVA, same time. Thank you again for joining us this week, and we will see you next Wednesday.